Director of Education, Integrative Psychiatry, I stumbled on these old video clips giving a brief discussion of bipolar disorder mixed symptomatology for a big pharma concern 11 years ago, if you can believe that. I had a goatee and I had different glasses and I didn't have all these highlights. But the message is the same, and that is most people who suffer from bipolar mood disorder, the old manic depression, suffer not just from mania or just from depression, but rather features of both poles of the illness at the same time. They have the worst of all worlds. They have the dysphoria, the depressed mood, the too often, the desire to be dead, and at the same time they have the irritability, the irascibility, the lability, the reactivity, the rejection sensitivity. These core symptom domains, very difficult to treat and really just very disruptive to life, and just plain old causes a lot of suffering and misery. Of course, that's what we do, partly, here at Integrative Psychiatry, is we evaluate people for this mixed symptomatology and intervene accordingly. I hope you get something out of these clips. Just as a note, these were mostly done for my colleagues, clinicians, and not necessarily for patients, clients, end users, consumers, whatever word you want to use there. But I'm going to go ahead and put them up on the website anyhow. Okay, that's all for now. Thanks. Talk to you later.
The most recent patient I've seen with a mixed bipolar episode actually presented to me depressed, and had I not been feeling particularly suspicious that day, I might have missed the concurrent manic symptoms. And that's the key with these individuals, is that they are simultaneously suffering from symptoms of both depression and acute mania. I think the most challenging aspect of the individual with a mixed bipolar episode is that we don't identify them early enough in their course. Early in this bipolar diathesis or illness, i.e. patients in their teens, 20s, a mixed state is often the most common mood state, more common even than the depressive, certainly more common than the manic moiety of the illness. But we tend to focus on the most obvious symptoms. If that patient presents mostly manic, we forget to ask about the depression. If, on the other hand, they present mostly depressed, we often will not scratch the surface deeply enough to elicit those symptoms of acute mania. That is the biggest problem with treatment, is we're not identifying them. As is so often the case, when a patient presents to me with any mood symptoms whatsoever, I'm taking a closer look to make sure that they are not suffering from a mixed bipolar episode. That being an individual who simultaneously suffers from and meets diagnostic criteria for acute depression as well as acute mania. And those patients, once felt to be rather rare, are now known to be quite common, very difficult to diagnose because we often don't think of the diagnosis, very difficult to treat, and often have a more malignant course going forward by virtue of the fact that we so often misidentify them and mismanage them. I think the single most important factor in our treatment decision needs to be the potential efficacy. And the reason that's so important is missing this diagnosis, giving the wrong treatment, leads to devastating consequences, to include disrupted personal relationships, a deterioration in social and occupation and scholastic functioning, and erosion of self-esteem and self-efficacy that leaves scars that may never heal. I go to great lengths from the beginning of treatment to warn them of potential pitfalls, anything that could sabotage even subtly compliance with these very efficacious treatments. And that really takes the form of counseling them about their level of activity, their diet. I certainly warn them up front that this is an agent that can increase your appetite. One's appetite. I don't say it can increase your weight, because I need to join with that individual to co-own the responsibility for management of the weight, just as I join with them for management of any of their symptoms or adverse events. So I'm very proactive. I use a lot of education up front. I have them back within a week or two and weigh them both before I start the medication and afterwards so that I can make an early intervention, either redoubling my educational efforts or going in with a definitive diet or nutrition plan or a consultation, a solutions for wellness, perhaps even use of other psychotropics, last choice. But if that's what that person's illness, that person's life, that person's brain needs going forward, then I'm certainly going to do everything I can to keep that person on life-altering treatment.